Hello.
How are you? Okay, can you hear us?
Yes, we can see and hear you. Good afternoon to
Good
everybody.
afternoon. Okay, good afternoon.
Dr. Colombo, my left, Pieter Smith, and many others. Just one by one, we will introduce them.
Okay, so I'm gonna start my session, and I'm D.W. Park from Asan Medical Center, first assistant, our Asan Medical Center alumni, Professor Yong-Hoon, and Chungnam Sejong Hospital. The fellow is Young-Sun Park. So looking at the moderator and panelist, I'm very happy. Many father exist, and young interventional cardiologists don't know. And Antonio Colombo is the first inventor of a crush technique. My memory was 2001 or two. First publication in the CCI journal about how can you do crush technique. The father of crush technique, Antonio Colombo. Also, Shao-Liang Chen is the father of DK crush. Also, Rubad is a father of a European bifurcation club, and the Sunao Nakamura is the father of a Japanese bifurcation, and the HS Paul Kao is expert in bifurcation. Many father is already exist in this session. So, and without further ado, and we start the patient, the presentation, and the Young-Sun, can you start patient presentation?
Yes, it's Young-Sun Park from Asan Medical Center. I'm presenting the afternoon first live case. A 75-year-old female was referred for cerebral disease on CCTA at outside hospital. She has been treated for hypertension and stable angina. The coronary angiogram, which was performed in Asan Medical Center, shows a total occlusion at proximal RCA and diffuse stenosis from distal left main to mid-LAD. The PCI at RCA CTO was performed 2 weeks ago, and revascularization of left coronary artery was planned. And past medical history, she has never had PCI before, and she has been on medical treatment for stable angina. And demographic characteristics, she has hypertension and she has no diabetes. And clinical presentation was stable angina. The baseline ECG. The baseline ECG shows normal sinus rhythm, and there was no Q wave or ST change. The chest X-ray shows no cardiomegaly nor pulmonary edema. The non-invasive studies, the echocardiography shows the normal LV systolic function without regional wall motion abnormality, and outside hospital CCTA shows the RCA CTO and diffuse disease in LAD and diffuse stenosis at left circumflex. Next, please. And baseline coronary angiography. The right coronary angiography shows the subtotal occlusion from the proximal RCA. So we have done PCI 2 weeks ago, and we stented 2 Zion Sky Point. And left coronary angiography caudal view shows the diffuse disease from the distal left main to the mid-LAD, and left cranial view shows the diffuse disease in the mid-LAD. And as well, the cranial view and spider view shows the left main bifurcation disease, and also in the mid-LAD. And spider view shows the left main bifurcation disease.
Also, we today check it up the coronary angio again. This is the area caudal view. You can see there is some significant region in the subaostium. Also, stenosis was extended in the proximal. And next one. So, and this is epicranial view, and by visual estimation, you can find that there is some significant stenosis from the distal and main to the mid-LAD part. The next one. And this is a spiral view, and absolutely you can see distal main was narrowed, and the LAD was narrowed. The subaostium is acute angle, significantly narrowed. So at this moment, 76 years female RCA was already collected, and today we're gonna do left main bifurcation region, some calcified region. At this moment, we would like to discuss how can you treat this patient.
Okay, so anybody wants to start first? What will be the first move? Besides
Duk-Woo.
placing wires.
Duk-Woo, hi, it's Michael Lee. Do we have intravascular imaging?
Yes, already done.
Is that available for us?
Yes, okay. So, and we're gonna show, it's before starting the IVUS evaluation. It's by visual estimation. How can you do in the, in the many country, we do every case IVUS evaluation, but the many European country and the US still overall status imaging guided PCI less than 20%. So it's just looking at the angiography, how can you do? Is Michael, and do you comment before knowing the intravascular imaging result? Yes.
But one of the first questions that I would like to ask to IVUS here is to know what the situation of the ostium of the circumflex. If it's calcified, how much calcium, because we know how weak is the ostium of the circumflex in terms of long-term result. Then there is also the diagonal that looks a little bit less dye. So my first question is the amount of calcium, and if I have to do something besides the simple balloon.
Dr. Park, I'm Dr. Hyunjong from Sejong General Hospital.
Okay.
Did you find any evidence about ischemia from the circumflex territory?
We didn't check the volume or treadmill test, and the patient presented this angina. We check it up the angio, and we didn't do any volume or treadmill test.
DW, can you share with us the CTA of this patient? Because we are looking at the angiogram, yes, but can you share the CTA with us?
Okay, the CTA is not prepared. Yeah, CTA is not prepared. Yeah.
Okay.
The CTA shows some significant left main region, and RCA was totally obstructed, and RCA was already collected where? So in the CT, we just know, and that there would be some significant left main disease, and also there is some severe calcification. So at this moment, we already check it up the IVUS from the mid LAD to the left main and the proxic and the left main, and then could you show us epicranial view and then IVUS? That would be helpful to match. So first view, epicranial view. Okay, here, and then you can catch up the angio, and here we evaluated IVUS. Okay, Professor Yoon, can you explain the IVUS finding? It's a much larger. Okay, go ahead.
Yes, I will show the diffuse calcified lesions in LAD from proximal to middle LAD. This is the target, and it's passing, and you can see the very big thermal burden at this site, and you can see some calcium arc at the 9 o'clock. This is diagonal opening, and the huge plaque is still going, and
here is the prox LAD part, and the vessel size is 3.5. Yes, and then the mid LAD also very tight. Over here is a plaque burden at least more than 70%. Here is the prox LAD part, and the diagonal branch is coming soon. Okay. Here, this is a huge plaque, it's a very tight region. Okay, so here is the septal branch coming, and diagonal branch 1 o'clock coming. There is some calcified region you can easily find. That would be this culprit region. By definition of angiographically, the moving picture showing the calcium that is by definition severe calcification. This is the LAD, the ostium, and the sock is coming. Here is the distal left main, and you can see plaque burden at least more than 60%. Vessel size left main more than 4.0, and the plaque was extended nearly shaft part over here. This is more than 5 or 6 diameter in the left main, and the plaque was nearly extended main ostium. Also, we check the ostium. Okay, could you?
Okay, so from these, what do you think? I think the LED should respond pretty well to balloon. I don't think you need anything special.
Well, apart from
Well, I think with the amount of
Stop.
calcium around the diagonal, I think you might, with balloon, you might end up with a dissection in that area, I think. So, yeah, I think that ballooning alone, potentially, I'm not sure that would work. And I was also amazed by the fact that in the mid-LED, it looked quite normal. The landing zone of your stent in the mid-LED could be very good.
what was the MLA of the distal left main stem? I mean, I appreciate there's a lot of plaque burden, but the MLA doesn't look too bad.
Okay, could you measure the MLA distal left main? Okay. MLA, this is a coming of a distal left main. Okay. Here is the distal left main. Okay. Okay, here is a 4.9, 4.85. Also, we're going to show us the sock that we already evaluated sock. Okay, Professor Yoon, can you explain? 에피코달 뷰를 바꾸고 요거.
Let's see the circumflex.
Okay.
That will be the most
Okay, go ahead.
interesting.
Okay, 크게 저걸. Okay, go ahead.
Circumflex and OM branch is coming, and vessel size about 3.5, and you can see diffuse and
Very big
uncalcified stenosis.
circumflex.
Yes, very
Very big sock.
Yes, and this is very huge plaque and very tight stenosis at proximal circumflex, and this is proximal suck, and still seeing a very large plaque. Vessel size almost 3.5, and
So far, not so much calcium.
No?
Yes, here, and the
And
sock,
here.
this is a costume. Yes, coming.
yes, it's very
Huge
huge
plaque.
plaque.
3.5.
Yes, and very calcified plaque.
Okay.
Here it
A
is.
little bit,
Also,
not
Yeah, not
nothing
severe.
dramatic.
Yeah, okay. And here is
this
the
is the ostium.
Ostium absolutely compromised the sock.
Yes.
After knowing IBUS, absolutely you decide your plan, every panel and every audience. We should treat the sock as well as LED, as well as distal left main.
Oh,
Dr. Park?
definitely, I don't think you need auto ablation. You don't need those kinds of things.
No, I don't
Maybe
think.
cutting balloon in some areas.
Yeah. So, and the epicranial view. So, and at this moment, usually we decide to, how can you do the dilated well over there? And usually on our experience, looks like a much severe calcified region. We frequently do cutting balloon or sometimes scoring balloon. So at first of all, we try to use the compliant balloon, just 2.5. How can you walk? And we performed the compliant balloon. And could you show us next view?
Dr. Park?
Next, yeah, okay, go ahead.
You already did the PCI.
Yes,
I was thinking about having the FFR.
You want an OMT for this patient?
So let me ask, based on this initial evaluation, are you already to make a decision how many stents, which kind of approach you're going to do on the bifurcation, or you want to wait?
Yes, absolutely. That is an important question. By visual estimation, we did 100% IBUS evaluation. We have a lot of cumulative experience, and we just guess is how much plaque over there. So, and usually, absolutely require at least one stent in the sock, and the LED at least 2, and at least 3 stent was required. But if you're gonna do IBUS evaluation, you can more concisely define how can our treatment strategy. We will do a crush or 2 stent or single stent that would be the benefit of the IBUS. Yes. So at this moment, we performed just a 2.5 compliant balloon, and we observed how can it work in this compliant balloon. And here is a sock ostium. We inflated up to 20 ATM using 2.5 compliance. is expanded well. Slowly, previous one.
What size balloon in the circumflex?
Yeah, this is a 2.5, and
But
we.
why 2.5? The vessel is 3.5. Why?
Yeah. Usually we do some not fully initial time is dilated. So just and we at this moment we find is a balloon expanded well or not, and the expanded well. After the very tight region was inflated and dilated. Even after putting the stent, we can the fully expanded using non-compliant balloon. And this is 2.5. We inflated well up to 20 ATM. That means vessel, the balloon size more than 3.0. And next one.
Yeah, Dr.
So,
Park.
yes,
Park.
yes.
I mean, the ostium's not really expanding as well.
Angiographically, so two bifurcated lesion, already circumflex, and also already diagonal. So this left man looks like complex bifurcated lesion. I think two stent, upfront two stent, is good.
Absolutely.
Provisional for already a diagonal bifurcated lesion. So also combined with the finding from the angiography and I feel a very severe calcification from proximal ID to left main. So I think before standing, I'd like to recommend to use shock wave to prepare the lesion. And I think, can you back to your previous image? Even the balloon from surface to left main was fully expanded, but the balloon is only 2.5.
Yeah.
So we could not assess if it's expanded fully or not expanded, because the left main looks like 4.5 or even 5.0.
Yes. So, even though we're going to use the less small size pre-dilation, and we expected well, even after stenting is expanded well that region, just this is 2.5, and the next one, and here is the 2.5, we expanded more than 20 ATM, expanded well, and the next one, and here is some calcified region, next one, we performed more than 20 ATM, expanded well, and next one. And here is the left main part, and next one. And also, this is after pre-dilation. You can see.
But if you use an undersized balloon, you will never be able to answer the question if the balloon inflated well or not.
Yeah,
Only
absolutely.
answer the question if you use an appropriately sized balloon.
So after ballooning, there is dissection, very clear.
Absolutely.
Dissection distal to the diagonal.
Okay.
So do you plan to project diagonal using third wire?
Yeah, just diagonal branch ostium is very wide, as I would like to do, just to stand crossover. And then we observed, our experience in the ostium was wide. Usually, is it okay? So here, this is epicranial very much more. This is a 3.0 stand.
So Antonio, if you were to do this case on the circumflex, what kind of balloon would you have selected?
I will take a non-compliant balloon, a trio inflated at 22 atmospheres.
Agree. If you use a appropriate size balloon, we will see the dog bone effect.
I will not use a 3.5 because I'm keen to go over 20. So to use a 3.5 at 22, it's a little bit too much.
Okay, test.
Okay.
Yeah, don't touch it.
Go.
Don't touch it.
Go ahead. 3.0, the 3.0 giants, length is 33, deeply.
Okay, this is
Why do not protect big diagonal branch ostium?
Okay, go ahead. Believe me, I'm sure. Not compliant. Okay. Save. Deeply. Okay. Okay.
So this is a 2.5 stent which you put in?
This is, on the basis of the IBUS, and we decide the exact stent sizing, and the mid LAD part 3.0, and the left main part is 3.5, and the suck is a 3.5. So, and in this live case, I'm gonna show our typical crush technique, balloon crush technique. How can you do? Okay, 3.5 NC balloon. So, we invited this session is father of TK Crush, Professor Shao-Liang Chen. Your comment would be very helpful. Is what is the difference in your TK Crush and our some balloon crushing? What is some important point we should consider during the crush technique?
Yeah, actually, you have pre-dilation flash. Definitely, if you use the two-slant technique, because all the annual Colombo is here. My personal recommendation is to use the DK quachi technique.
Okay, this is a 3.5 NC balloon. Put the LED and for anchoring.
So you are going to do balloon quachi, right?
Yeah, absolutely. Yes. So suck is on the basis of just checking angiography. Many physicians select 3.0 and IBUS evaluation. One of the merit you can much larger stand with confidence and the based on the IBUS and on the basis of the IBUS and we confirm the vessel size is at least 3.5. Okay.
We have Yves Louvard that is really expert on bifurcation. Can you tell us your opinion about?
여기서 앵커링 6, 6.
No.
Okay. 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 Some anchoring is very helpful. Over here, this is a sock. Okay. This is LED. Okay, test. Okay, good. And the spiral view. Spiral view. Okay, I'm gonna do.
So I feel you need to little bit pull back this stand from the.
Okay, much pull back over here. And the sock.
Well,
okay.
Shao-Liang, may I ask you? Usually in this situation, we usually crush, we put in the stand in the circuit and crush it first, right? But let's say if the circuit is the bigger one and LED is actually smaller.
Yeah, I think it's a good question. Even for some cases, LED looks like smaller than some flash. So we still use the LED as the main method.
Still crush the circuit.
Yeah, right.
Okay, 12, 14.
If you do a two-stand technique, this angle is not so bad to consider a T-standing also.
Yes. And 12, 14.
Considering the angle.
Because the left main is very big.
Almost perpendicular.
It's not bad.
So we put the 3.5, another giant stand. The length is 23. Okay. So at this moment, we're gonna do high pressure NC balloon dilation before crush. This is one of the critical steps for.
But what would you do? What we will do here, we will predilate the circumflex and be provisional. And if the result is acceptable, we will do DCB on the circumflex.
There will be a more kind of modern way of.
Okay, I have one comment.
The ostium of the circumflex doesn't seem to be very well expanded either.
Yeah, if we will make the decision after predilatation.
Yeah. So
which doesn't mean that we're not going to stent, of course.
You're going to do
with the proper size predilatation.
So Antonio, one more question. Do you prefer to do side branch using DCB before, after
always after appropriate predilatation, I make the decision. Because otherwise it's a waste of money and time. Because if the predilatation is mediocre, you know already that.
My question is that after predilation for some flash, angiographically very good. So my question is that, do you use DCB before, after standing main vessel?
Or after,
okay, boy.
After stenting the main vessel. After stenting the main vessel.
So one bifurcating TCB randomized trial is ongoing. Next year we will have 1 year follow-up result. For this trial, TCB will be used after stenting.
After stent, yeah, because the problem is that after you stent, you may have deterioration of the side branch. So you really need to use DCB when you know that the result is good.
Right. After stenting main vessel, post-dilation, and rewire, very well pre-dilation. Again, pre-dilation for some flash. But one concern is about the loss of the drug on the DCB.
Yeah,
right.
That's we need the study for that.
22.
So how big is the balloon?
So this is a 3.5 balloon.
This is 3.5 ansible, no? 자, 22. Okay. You know, there is expanded well, deplete. And here we moved all about the sock and the balloon and the wire. Okay.
Do you want to take one more angiography before reading?
Yeah, absolutely, absolutely. Sure, the video crush is go ahead. 10, 12, 14, 16. This is 3.5 ansi balloon, deplete. One more, 20. Okay. Okay, deplete.
Yeah, you want to have an angio before they crush.
Absolutely,
is that correct, Shao-Liang? Yeah?
Right.
Right, to see if you have no distal dissection on the circ. Exactly. Because, yeah.
Deplete.
Yeah, sometimes from the epicaudal view, there is a
slight
foreshortening.
We used to recommend this because if you have to advance a stent, it's better to do it now.
Exactly.
Dissection in proximal ID. It's not too severe. So do you want to move to...
Absolutely, there is some dissection of epicranial view over here.
The problem that after stenting, the results are so good that it's so difficult.
Okay, stand, ready?
Does the patient have chest pain right now?
Yes, patient is okay, and she is okay.
Congratulations.
And sharing your comment would be very helpful to audience. And balloon crush and DK crush is what is different, and why do you emphasize DK crush? What is the key step of the DK crush? Many Korean audience want to hear your comment. Is how can you do DK crush well?
Thank you. Because immediately after stent crush, there will be 3 layers at the orifice of circumflex. So I think this is a key problem for calcium crush. What's the stent size?
Okay, test. This is a 3.5?
3.5.
Okay. 뒤에는 충분하네.
Yeah. 2 millimeter overlap.
Yeah, absolutely.
Good. Okay.
This is stent booster, and the overacted well, and then the left main ostium, just ostium was skipped, tested. Okay, you can move to back. Okay, test.
Yeah, no cover the left main.
Okay, good.
Good position, I think.
Yeah. 다시 한번 이 뷰가 잘 보이나?
I feel there is a small gap between 2 LED stents.
약간 갭이 있네, 그지? 조금 더 들어갈게. Okay.
0.5 millimeter gap.
Yeah, absolutely. 한번 이렇게 한번 다시 체크해 볼게요. It's good. Test. Okay, go ahead.
But in a case like this, where I have to be precise on the ostium of the left main, and I need to control the overlap with the distal stent, I will do the opposite. I will stent proximal to the
3.0 먼저. So at this moment, we're gonna do
now I have. I wish I can stretch the stent, but I cannot.
So, and just left main ostium was, even though there is some plaque, and the lumen is more than 14. Yes, and we can exactly match the left main ostium. Okay, this is a 3.0 non-compliant balloon. We should make sure in the optimization that is most important part. So, and the distal, we put the 3.0 giant sky point, and this is a 3.0 non-compliant balloon. Okay, go ahead. 10, 12, 14.
So, Dr. Colombo, do you have any
14,
recommendation
16.
about the selection of non-compliant balloon for
16,
post-dilation, also for port?
20.
No, I take what they
Okay,
give me. I take as long as it's a non-compliant
Okay,
balloon.
20.
Do you have any
24. Okay, this is 3.0 and then 3.5.
Some Japanese balloon we can inflate, like acute force, we can inflate to very high pressure. Acute force up to 28, no rupture, according to my experience.
Actually, Japanese balloon maybe up to the 30. So he has a 40.
40, yeah.
So this is a 3.5 non-compliant balloon. We're gonna do very aggressive high pressure balloon for the proxy LED and the left main part. Okay, higher.
Now that the very proximal left main and the ostium is not covered by stent, I think we should be careful with the final kissing and the part.
Absolutely. Okay.
We don't injure the proximal uncovered area.
16, 18, 20.
So this is a 3.5 and
22. Yeah, 3.5. Okay, save. Deplete.
Very beautiful.
22, 24, 26. Okay, deplete. And we're gonna use the stent booster to exactly match with the ostium. Okay, over here, go. 10, 12, 14, 16, 18, 24, 26.
26. So the
Okay,
balloon is
deplete.
out of the left main stent.
Yes.
Yeah,
So here, and then we will check it up the angio, and just we remain the one thing, final kissing balloon dilation. Distal part we already done using 3.0, 3.5. Circle we already done high pressure. Just the one remaining thing is about the final kissing balloon dilation. Okay, angio ready? 라이트 좀 줬죠? Okay, angio. Yeah. It's good. LED. And we need some nitro.
The 3.5 non-compliant balloon is too small to optimize left main.
Good.
What about that diagonal?
Yeah, Ives will tell later on.
Diagonal.
Okay. Okay, there is some loss of diagonal. And
diagonal is invisible.
Yeah. So we try to the open, and then after push the circle wire, and then try to open the diagonal branch.
Right.
You know, the rule that you always have to finish with the same number of vessels you started.
Absolutely. Make sure we try to do our best. Same number. Choice PT 하나 주고 diagonal branch.
So I think this is very typical of our case to show how bad the provisional, right? After standing LED, diagonal disappear. It's very common. What wire are you using? Dr. Park, what's the wire? What's the third wire? What's the wire are you using?
This is a Sean blue wire for sock, and then we're gonna use the choice PT wire, some opening of the diagonal branch.
Okay.
You're not going to do a pot in the left main before you start trying to wire the circumflex?
Yes, we don't usually do the pot.
But how can you be confident that your wire is in the middle of your stent and not outside of it?
Yeah, so that is one of the important issue. The Shao-Liang is prefer the proximal part wiring, and we usually use in the middle, and distal part would be okay. So, and looking at this moment, and past the Shao-Liang preferred position is proximal part. So, and the choice PT And could you show spiral view?
Does the patient have chest pain, or if there is change of EKG right now?
Yeah, the patient is stable. Okay, 한번 cranial 보여주고. So, and if you have time in the visit another room, at the time I'm open the diagonal branch. Okay.
We see some elevation and some depression and elevation in one. Yeah. So, would you have wired this for this professional stenting of the LED? Would you have put the wire in the diagonal before you put the stent in?
Yeah.
Yeah.
Absolutely.
Yeah.
3 wires.
Okay, good. So I think we have the other case presented.
Yeah.
Please go ahead.
Good afternoon. I'm Dr. Kang, and here is the Asan Medical Center, and just the closed room. And I will introduce our team. I'm Dr. Kang, and he is Dr. Hanbit Park from the Gangneung Asan Hospital. And he is our senior interventional fellow, Chen, and our senior technician, Kang Hyunjong, is also joining the procedure. And Dr. Chen, can you please present the case?
Yes, I am Yong-Hoon, a clinical fellow. Let me start the presentation. This patient is 57 years old male, and he was referred for chest pain. He has been treated with hypertension and hyperlipidemia. Coronary angiography showed severe diffuse stenosis proximal to distal RCA and significant stenosis at left main to mid LAD with diagonal bifurcation. There is no past medical history. Next. He has hypertension, hyperlipidemia, and family history of ischemic heart disease, and her smoking status is ex-smoker. The clinical presentation is stable angina with functional class 2. Next. EKG shows normal sinus rhythm, and there's no specific changes. Next. Chest X-ray shows no cardiomegaly, and there's no active lesion on both lung. Next. Echocardiographic findings shows normal LV systolic function without regional wall motion abnormality. Next. This is right coronary angiography. Right coronary angiogram shows diffuse stenosis proximal to distal RCA, and we have already treated this region with Synergy XT stent and agent DB. Next. This is left coronary angiogram. Left coronary angiogram showed diffuse stenosis at distal left circumflex artery and left main to mid LAD. Next. There is a significant stenosis at diagonal bifurcation. Next. This is QCA of left main disease. The degree of stenosis of left main is about 50%. Next. Our target lesion is distal left main and LAD with diagonal bifurcation and distal left circumflex artery. We planned the PCI with IBUS.
Can you please show the previous one? Yeah. And no, can you please show the slide? Yeah. Minus. Yeah, can you please? 57 years, relatively young patient with a triple vessel disease. And left main, I have some concern that is that the real left main disease or not. And the patient actually declined the CABG and visited us. And for RCA, I implanted one stent and distal diffuse region, applied DB, and the result was good. And now, today we will treat the left region. Then I want to ask the expert panelist that how would you treat this patient? How would you stent or evaluate or treat?
Who wants to?
Yeah, may I start? Okay. So angiographically, distal left main looks like no bifurcated lesion. Also showing flash looks very good. But I think we need IOS to measure the minimal lumen area for distal left main. But very complex bifurcated lesion for ID and diagonal. On the other hand, also show diagonal looks like 50 to 70% stenosis. So my strategy will be that after get more information from IVUS, I will use a provisional stand-in technique for AD diagonal with the drug-coating balloon for diagonal. Thank you.
I want to ask to Dr. Chen, then, is it the definition criteria significant diagonal or not?
Yeah, actually, according definition criteria, so the side branch diameter stenosis should be minimum 90%. So this is why I recommend to use provisional and DCB.
Okay.
Thank you.
Yeah.
Thank you for your
I agree. I would do the same. The circumflex definitely looks fine. I don't think there is some disease in the circumflex downstream, but
I would leave that.
You can do it later or now, as you like.
Or up front.
Yeah, up front.
Because if you do the provisional stenting of the left main LED,
you should do it up front, unless you decide to do it later in the future. But the circumflex is. This is, for example, is one typical lesion in the circumflex where we would try to do DCB, because it's long. There are many side branches. If you start placing a stent, you're going to waste 1 hour to protect all the branches. With DCB, maybe you can get out just protecting the OM. That's it.
But the patient may be asymptomatic, so there would be no indication to go after that circumflex after you've fixed the left main and the LAD.
Yeah, I think it's also a valid point. And if he becomes symptomatic, you can do it later on. That will be a reasonably incomplete revascularization.
And for circumflex, I think that, as Colombo said, that circumflex has an intermediate stenosis. So because we are the FFR guided center, usually we measure the FFR for this lesion. Next.
But
Can you please show the FFR?
Let's concentrate on the LAD now.
Yeah.
Right.
This is the FFR pullback from the OM branch, the largest OM. And then at the bifurcation lesion, it increases to the 0.85. And at the left main, there was a little bit more increase, about 0.15. And actually, the distal OM, and also I put the wire a little bit to the proper circumflex, and the FFR was 0.5. And we know that in those cases, the patient has a significant ischemia at the distal OM and distal circumflex. So actually, I want to open those cases. And I'm so sorry, but I did not use the drug-eluting balloon next. Unfortunately, next, wire and balloon and stent test very well, easily. Next, I just applied 2.5 and checked the IVUS, and IVUS showed not very severe calcified disease. Next, and implanted 2.75 and applied 3.0 NC, and next, previous, and I finished the circumflex procedure. Unfortunately, it did not take so many minutes, and I will show you the final circumflex run from the distal OM to left main. Here is the IVUS at distal OM, and I placed 2.75 stent by 20 millimeters, sorry. And this is the OM, another OM branch. And here you can see the calcification. Another OM branch came in.
Did you remeasure FFR after stand-in circumflex?
Actually, I did not measure FFR again for the circumflex because I used the IVUS and I performed my best to obtain the good stent of position with the NC balloon. I can further dilate, but further dilation will make damage to the branches, so I negotiate here. And then checking the FFR, post-PCI FFR again to circumflex branch does not give me any more information. what I want to measure the FFR is actually left main. So now I will move the topic to the LAD diagonal. Can you please see next one?
So before standing circumflex, left main FFR is greater than 0.9. So
Yes,
probably
0.9.
it means the left main lesion is non-significant.
Yeah.
Do you
Yeah,
agree?
so actually the step up at the left main was 0.15 at the circumflex pullback. And I think that in those cases, I hope not to cover the left main as Dr. Colombo recommended. And I will check the IVUS with the LAD. Actually, I applied 2.5 NC for tightest with the LAD region to open the lesion. And this is post 2.5 pre-dilation IVUS. IVUS is coming into the LAD. Yeah, here's the mid LAD. Let's see. This is 1 millimeter pullback, and the plaque begins. The vessel size is 3.0. Oh yeah, angiography. And here is the calcified region, and I applied 2.5 NC here. The calcium is not a very concentric, but the lumen is okay. And here's a diagonal opening. Diagonal branch came in from 12 o'clock. Previous one. NGO 다시 보세요.
Yeah.
Delta FFR was 0.15.
0.15
before the
left
stenting,
main.
and then we treated the circumflex to OM branch.
Yeah, that's a great idea. Yeah.
And then the pressure gradient in the distal left main will increase.
Here is the left
more
main.
than 20
Let's see.
or 25. Yeah.
There's some calcification protruding to the left main lumen. Because the image quality was not so good at left main, I will show you again after some more flushing.
So how much minimal lumen area for distal left main?
Actually, I measured it from the circumflex pullback. It was 4.5. 4.6, yeah. And in European guideline, and the European data and the De La Torres data shows that 6.0 is well matched with the FFR 0.8. But our data shows that 4.5 was well matched with the 0.8. Maybe there is some difference in the vessel size and body size. And I will show you again from the prox LAD here to left main.
So this is the proximal LAD?
Yes, proximal LAD. And this is circumflex ostium.
Okay. So
And here's the
proximal
distal left main.
yeah, proximal ID looks good. So
Yeah.
if you pull back the IVUS catheter from circumflex, so the middle left main minimal lumen area is slightly smaller than the measurement from pullback from LAD. So
Yeah,
I
can you
think
measure
from
the
this round,
MLA again?
yeah, from this round, I think this left main minimal lumen area should be around 5.0.
Okay, this is 5.0.
Good. I have IVUS eyes.
Yeah, great. And this is the example of the intermediate left main, I think. The angiography was a little bit ambiguous, but was eccentric, but in some view, there was 50% QCA stenosis. And usually in guideline, other disease, 70% is recommended for revascularization, but left main is now recommended at 50%. But in Excel trial, 70% the left main is recommended as the revascularization, and 50% and then needed more on FFR or other physiologic evidence. So Actually, this is a very ambiguous left main. So actually, we are planning another randomized control trial for this kind of lesion. 50% angiographic stenosis, and to treat or not to treat, just by angio guide versus FFR guide. And we are just beginning at that FFR guided left main PCI trial. And can you please, then I'll set my plan, because the proxy LAD is clean, and if I place one stent, one a little bit long stent, I can cover whole LAD region with one stent, and then optimize the LAD, and then we'll measure the FFR for left main, and let's see what would be.
Right, greatest strategy, greatest strategy. I think probably there is no need to stent distal left main.
Yeah, this is the very routine procedure in imaging and FFR guided PCI. And you can see that FFR IVUS measurement, that if we put the 3.0 by 48 stent, we can cover whole region with just one stent. And I want to ask the expert again about the diagonal branch. Do you routinely perform the predilation or DB for this kind of lesion, or just cross over and do a provisional approach?
Yeah, as I said 2 times, I will use a long stent for LAD and the DCB for diagonal. So before stenting, I will recommend to use 2.5 NC balloon for diagonal, and then stent LAD followed by DCB in diagonal, and find a kissing in final port.
Yeah, I will predilate the diagonal 2.5 non-compliant balloon, so you get this decision already available.
I feel you are me.
You see, I would offer the contra opinion.
What
I wouldn't predilate.
You touch the diagonal.
I would leave the diagonal alone.
Would the touching the diagonal harm the diagonal branch or not?
I would just go for professional standing of the LAD after predilatation and would not touch the diagonal. If you put the balloon there in already up front, you might end up in trouble after professional standing.
You can also leave the diagonal as it is. It's not a must, but I think whatever is a matter of decision, personal. I will still, the diagonal is not so small. I will try to improve it.
But the concern is that from spider view, so the LAD and the diagonal looks like type Y bifurcation. So it means very narrow bifurcation angle.
Yeah.
So
Can you please show the
after
side
standing LAD, probably coronary shift will cause, will pinch diagonal much more.
But let's see, do something, let's see.
Yeah, yes, you mean that. And in this case, if I check the IVUS to diagonal, then I cannot cross over. That will be a heavy flag maybe, definitely. Okay, I will do the provisional stenting, not to make damage of the left main plug. Gently insert the long stent. So this is long stent.
What is stent length? 38? 38? Yeah. 48? 48.
48 to cover the whole long region with one stent. Some resistance, but going well. Test. Okay, a bit more. A little bit good position. And we'll check the caudal view. Just good landing zone at the proximal. Test. Oh, I should go more. And the left main looks more severe in this view. Test. Okay. Do you agree with this landing zone? I'll check the distal again. It seems a little bit long. Test. But will be okay. I need 43.
So, Dr. Paul call Hsien-Li.
Yeah.
Because of the wide discrepancy in the vessel diameter between distal AD and the proximal AD, would you prefer to use 2 relative short stent or 1 very long stent? Which one is much better?
Well, I would size to the distal LAD and then max up the proximal part. Because if I use two stents, I might end up overlapping the diagonal ostium, which will cause even more trouble. And nowadays, these modern stents can be oversized significantly.
Deflation. Because the patient is stable, I inflated a little bit longer time. Okay. Okay. Shall we check the angio? Angio. Okay. You can see the pinching of the diagonal branch.
This is because of the
Pinching,
climate
but
shift.
flow still good.
Yeah.
Would not do anything.
Then-
Post-delayed.
So
yeah.
after post-dilation and then angiography again.
And I want to ask the expert panelists that I will apply the NC balloon there. And do you rewire the lesion before NC, or just keep the wire and put the NC and then remove the wire?
Just keep the wire diagonal. So from angiography, it looks like there is a distal edge dissection. So probably we need a multiple projection to see.
Oh, yeah. No, we have IVUS. We can
right.
see.
Okay, I was.
Can you please give me some nitro? Another possibility is the spasm.
So what's the NC balloon size?
Oh, I will use 3.0 for distal, and we'll apply bigger balloon for proximal.
Okay.
Let's see. Proximal size was more than 3.5. There was some angiographic hedginess. Okay. Wire kinking. What?
I would repot.
I will not
before.
go. Yeah. I will not.
After pot.
Why don't you post-dilate
No, I will.
before?
Let's give me
I will
NC.
post-dilate before
Yeah.
doing
When
that.
patient stable, flow is good. I do not mind. So it's so much.
You have to post-dilate anyway, so I think it's...
Oh, yeah. I will not.
Well, personally, I would rewire the diagonal before I pot, because otherwise the wire would be jailed so hard, sometimes pulling out would be difficult.
But in those, I will rewire because most probably I would like to do something on the diagonal. It's a little bit... but,
Actually, before post-dilation, don't remove the side branch wire. The reason is that once the diagonal disappeared, so the jailed wire could serve as a road map.
Yeah. I'm not saying pulling out. I'm saying rewire from within the stent into the diagonal. Because now if you pot the proximal, the jailed wire will be jailed so hard, sometimes pulling out will be difficult. But I agree, I will not pull it out without any wire into the diagonal, because if it's out, it's difficult to rewire into.
Okay, Hsien-Li is an expert of...
I think that depends a little bit per case.
what are you doing now? Tell us.
Oh, yes. I am introducing the 3.0 balloon to
2.
LAD and 3.0 for this type optimization first. But there was some angle, so it's some difficulty to 3.0.
Zero. This is because of the angle changed between stent and proximal ID.
Yeah,
so right now you
Yeah.
can slightly pull back the diagonal wire and to get the guiding deep seating.
I want
think,
the deep seat.
Yeah, that will
Because the left main
facilitate-
region, I'm
Right.
not doing the deep seating of the left main guiding. If I do that, it will be easier, but the problem is that
Yeah, because the
can you
guiding
please give me a smaller, softer one?
because the guiding support is not it's strong enough. So in this scenario, we usually to slightly pull back the side branch wire to get the
Yes.
guiding deep seating.
I mean, another way of doing it is use a guideliner.
Compliant. 아까 처음에 나온
You have to change the angle of the guiding catheter, so
Yes,
you change
absolutely.
the bias of the wire.
Yeah, I think anything
the
we do,
balloon
we
was
have to do
very-
it gently, because this is
Yeah.
when the longitudinal deformation happens.
Or sometimes
Yeah,
even
that's
inflate
right.
the balloon a little bit. It will make the balloon go
So can you use a short NC balloon?
Yes.
Short one.
Is it a semi-compliant or a compliant or a non-compliant?
No, I used the compliant because it was the NC balloon that I
think
usually use the very
rewire
stiff
the
one.
diagonal and pull back, rewire the diagonal first, and then pull away the gel wire.
compliant 하지. 예, compliant 열고 들어갑니다. Actually, in usual this situation, impact the guiding, as Dr. Colombo recommended, to make another angle. It works and NC easily passes. But the patient had left main disease. I do not want that. So I will use another weapon with a more soft
way
balloon.
is when you touch the stent, inflate the balloon at 3 or 4 atmosphere, and then it will move a little bit the balloon.
Yeah,
or just use a semi-compliant balloon.
Struts at the beginning of the stent.
Take the nose out of the struts. Just at low atmosphere, 3 or 4.
Or use a semi-compliant balloon, that you might be able to get that round easier.
Very wide angle.
Inflate the balloon.
Maybe crisscross of
But
2
if I
wires.
inflate balloon, I can touch
crossing.
the left main. Will it be okay?
Yeah, but low pressure is gonna caress the left main.
Okay, I just changed the angle.
You got
And
it.
cross this
Congratulations.
way.
Congratulations.
Okay, 2.5.
This is 3.0 or 3.5? 3.0.
No, it's a 3.0, but not NC. This is
2.5.
deflation.
More high pressure.
Okay, 18.
So the angle is very clearly.
Okay,
Good.
deflation. Now I will use the NC. This is semi-compliant. I tried to just open the opening, and now we will use the NC. For distal calcified region, I need a non-compliant. 아까 나온 거 주시면 돼요. This is the situation that I cannot find a good answer anywhere. I asked my seniors about the diagonal branch, provisional or balloon first, or wire keep or rewire. Everyone says different. Everyone answers different answers. That's the very simple but complex situation.
No final answer for your question. It depends on the primary operator's experience.
Okay.
Still difficulty.
Pull the guide a bit.
Okay, then. I will rewire the diagonal and remove the gelled wire. Then it will work. Okay. Wire, please. 와이어 하나 더 주세요. Some interaction between the that oppose the stand proximal strut and angle calcification and gelled wire makes some resistance. I can push, but it can make damage. So I will not.
Nothing to hurry, because
Okay.
patient is very stable. EKG looks good, pressure is fine.
I'll be hurried to. I have to measure the left main FFR.
So, Dr. Colombo, can we switch to the previous case?
Yeah.
Yes.
Can we?
Okay.
Yeah, that's a good point. Can we go back to the case 1 to see what happened so far? They had to rewire the diagonal. Is that possible?
Okay, please. Yeah.
Do you want to rewire from distal cell?
네, 일로 한번 옮겨. Okay. So Antonio, can you see?
Yeah.
Yes, and as you find, there is some wire passed where, and we did everything. And could you, okay, Chang, can you?
Which wire did you use to
Yes. At the moment, we're gonna show, and and the diagonal ostium was after, before final kissing dilation, after stenting the main, after high pressure ballooning, is diagonal branch was gelled. So we used the initial, here, and the next one, and next one, and absolutely the diagonal branch was gelled. We tried to some wire, initially choice PT wire does not work, and the field XT wire does not work, and final choice, much strong wire, the Gaia first, and the next one. And take a time, it's more than 10 minutes, less than 15 minutes. Next. So, and here, next. And the previous one, and at the overlapped moment, is wire was the past true room, and this is Gaia, the first wire, and the positioning over here, and we try to some time, and we push the wire at the moment, and past that here. This is a diagonal bench. So, and the next
Gaia
one.
first.
Yeah, Gaia first. And here, next one, and we find true lumen over there. We perform the 1.0 compliant balloon, and the next one, and the next one, and the 1.0 next one, and we next one, this is 2.0 compliant, and we found that the flow was restored, and then the wire was passed, and then we use the freely anchoring LED balloon using 3.5 balloon, and initially circle ostium is past 2.0 small balloon, and the next one.
Dr. Bach?
Yes. Okay, here, and we did the high pressure balloon dilation in the subostium using 3.5 NC balloon up to 14 ATM. And next one, and here is a sequential high pressure in the left main, 3.5. And next one, and then here we did a final kissing balloon and using the 3.5 up to 12 ATM. And next one, and then we move to the proximity part, and the suck is 2.0 compliant balloon, and the next, and then here is we try to do kissing in the first diagonal branch and LAD next one, and here is NC balloon 3.5, and next one, and we did additional kissing balloon 2 times, next one, and this is the view. So at this moment, I'm gonna check it up. The coronary angio, okay, angio ready. Vital was stable. Test. Okay, angio ready. Okay,
why real-time ECG showed the significant ST depression in
we don't
lead?
know. We don't know. Yes. So and the patient is now stable. So and we removed much strong wire over here, and this is the Gaia first wire. Flow was fully restored, and the patient vital was status, and then we will check it up the final IBUS.
Dr.
Yes.
Park, congratulations to the very, very beautiful result. Just one question. Before kissing balloon inflation, so the crushed segment localized as a distal left main, but after kissing balloon inflation, so the crushed segment moved to the osseous circumflex. So I suspect the full coverage of osseous circumflex. Can you check IVUS study from circumflex?
Absolutely. We're gonna check it up here, and then here this is IVUS, and we can see this is LAD. Is a 2. We're gonna do distal part over here. Okay, can you play back? Okay, this is 0.5 speed, and then the distal LAD we can find over here. We try to hear, and there is no dissection, but there is no inner position and the expanded well. We will make sure the prox LAD and then the distal main. Okay, here is the expanded well. There is no under expansion area. We fully expanded over here using 3.0 and 3.5 NC balloon sequentially. And during the procedure, some ECG can change. We cannot at the time. So what is the ECG change region? It doesn't matter. Absolutely, yes. So and here and the fully expanded well. So here is prox LED was expanded well. The diagonal branch ostium is coming here 1 o'clock. Over here is opened well. You can see is open the well. We did is a final kissing, and then this is a LED ostium. You can see the crushed part. The suck is coming. Over here is 3 o'clock. Is coming the suck just to Carolina over here, and we can see this left main and fully expanded, not circular. For make sure circular, we do additional tap. But I think we don't usually do the final the additional balloon, and this is fully expanded. The main is a yes, and also we're gonna quickly show the quickly show the subostium.
Can we see the circumflex as well?
Yeah.
Okay, absolutely,
so far
absolutely.
looks very good. Huh?
Yeah.
Congratulations.
Yes. So, and the patient's vital status is okay, and the blood pressure is okay. She didn't complain any chest pain. And then we're gonna surely check it up. We put the 23 stand for the 3.5 in the sock, and here we make sure. Here, okay, go ahead. Okay. Here is the sock. The distal is well expanded. Okay.
So this is the 3.5 stent.
Yeah, additional 3.5.
Yeah.
There's a nice symmetry.
Yes. Nice symmetry. Okay, here is the subostium. It's open the well. Here is the subostium. It's open the well. You can see this is distal main. Yeah. Absolutely is a perfect IBUS result. We're gonna quickly show us the final result. Okay, angel ready, everybody? Okay.
Also, can you have your technician to focus the IOS from the on at the osteo circumflex?
Angel. It's good. Sock is good. And then epicranial view. Okay, good. So I think, every vessel I saved is a pre-treatment number of vessel after treatment number of vessel is the same. And this is could you show spiral view final? And this is, I think, a typical example of the left main complex region. How can you treat? How can you do balloon crush? The crush technique for distal main, and this would be. I hope the audience learns of a lot of things.
Okay.
Yes.
And
thank you.
in this patient, for how long will you give DAPT in this patient?
Yes, usually we prescribe at least 1 year, and then after 1 year, and depending on physician discretion, and some physician just used Plavix alone, and some physician more use the 2 years up to 3 years, depending on physician. In my case, after 1 year, I just Plavix alone. Yes.
And any follow-up, CT follow-up, any?
Yeah, it's a post-PCI published in New England Journal of Medicine. Did not recommend the routine, surveillance stress testing. In the symptom-oriented surveillance we do, and after publication, post-PCI in New England Journal of Medicine, we don't do routine any functional non-invasive stress test.
So,
beautiful.
Dr. Park.
With this beautiful result from Dr. Park, and one comment from maybe that we wanted to see the ostium of the circumflex on the OCT, because with IFUS, because you mentioned that if you enter to distal, you might have a proximal part that is not covered, but if they entered proximal in the circumflex, so I think the ostium of the circumflex is fully covered by stents.
Absolutely, yeah, that is good point. And the Shao-Liang, could you comment on that in the TK case? Which point would you try to pass the side branch wire in your proximal or middle or distal?
Yeah, usually we revive from proximal cell, Dr. Parker, for your case, I still have two questions. According to I was finding, if there is a gap between two stents in LAD, angiographically it looks like there is a gap, almost 0.5 millimeter. Secondly, I still wanted to learn much more from circumflex IVUS. So can you show the IVUS focusing on the osseous circumflex? Thank you.
Thank you. Great. Okay, thank you to all the moderator and our
congratulations,
panel.
very
Thank
nice
you.
case.
Okay. Yeah.
I think we have 5 minutes. Maybe we see the second case. Yeah, here, 5 minutes.
Okay.
I did some rewiring to diagonal branch, and then balloon crossed very well. There will be some the artifact because of the balloon and stent at the proximal edge, and applied 2.0 compliant and did the DB at the Colombo requested and did the kissing. Can you please show the kissing final? Yeah. And apply 3.0 and 3.5 proximal and check the IVUS for the full optimization. Because of the level time, I will just finish with the left main FFR. This is the FFR wire.
Okay, would be interesting.
Yes,
Who thinks it's going to be positive? Who thinks it's going to be negative? Namas, what do you think?
I think it's probably going to be negative, but I would still fix it. Because you've got a positive IVUS. Your MLA on IVUS is positive, so if the FFR is discordant, I'll still go for
zeroing. Okay.
I think it's going to be positive.
You think it's going to be positive?
Let's see.
I think it's going to be.
I will not be surprised if it's positive.
I
Because
think it will be positive.
some positivity may be due to the instant.
Yeah, definitely positive at this time.
Because it's never perfect.
Then how about the decision for if the left main?
The diagonal. Look at the diagonal.
You can also check the diagonal.
That's a good point. Okay, here is the distal LAD, and let's see the resting index, please.
Yeah, put the distal from all the
Let's see
disease.
the PDPA.
Okay,
Let's see what is the PDPA.
It's going to be positive.
Yes. Can you show? Yes. PDP.
So from
Okay,
registry study by Dr. Koo.
You see, PDPA is 80.
So for LAD
because
lesion
we just
post-staining,
injected saline, it needs some time for recovery. It's saline-induced hyperemia. We need some seconds.
You know, but if the PDPA is 83, 84, you don't need to do FFR.
And let's give some
It's already, it's going to be positive.
You're going to be positive. You don't need any adenosine, nothing. You just inject some contrast.
so Dr. Kang, can you slightly pull back the guiding catheter from the ostium?
Oh, yeah.
Thank you.
Did you engage the guiding catheter from the left main ostium?
Oh, yes, fully disengaged.
Yeah, big time.
Okay, as you want, I will fully engage.
I did not expect it.
Okay. The value is 0.85 now. And adenosine?
Yeah, Dr. Koo
But
has
you know,
reported.
when we have this number, we just do with contrast.
Contrast FFR. Yes.
If contrast FFR is
Yes.
79, you know that is positive.
Yeah.
Then
don't
I want to
waste
ask a question
adenosine.
if the lesion distal
But you
FFR
know, for
value
sure,
is
if PDPA is 83,
0.7879,
84,
then treat
it's
left
going to
main.
be positive.
Dr. Koo has reported post-LAD standing if the FFR less than 0.89, so which could predict the occurrence of clinical
It goes down.
after event.
Is this adenosine?
Yeah, adenosine.
Yes, adenosine, intravascular adenosine.
You can stop it there.
Yeah.
And then at this time, I will do pullback.
But
Here it says
you
10
know,
distal.
I'm not surprised that even if you treat the left main, you're still going to have a positive FFR.
Yeah,
Because
because there is some distal lesion.
No,
after
because the inside the
proximal.
stent is not perfect.
Yes,
it is never going to be
100%
perfect.
agree. And 0.78 here, and proximal edge here. Distally, we treated our best.
Yeah, so
and
it looks
proximal,
good for left main disease,
Yeah.
right?
0.78. 8. Oh, no. It's a
Okay,
little bit
no more
out.
for left main.
This is for left main.
Yeah, it's still positive.
Okay, then I will treat the left main with the crossover. It's
Yeah,
a very
and repeat the FFR after you treat the left
and I
main
will
and
check-
send us Twitter something.
check the zero. Yeah, zeroing is good. And left main use all audience so many cases of the left main, especially crossover. So I will finish the demonstration here.
That was a very, very teaching element.
Thank you very much.
Okay, thank you. Thank you to everybody. Thank you to the operators more than everything.